Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Good morning. Welcome everyone to our first case discussion in the webinar series. Good morning to Professor Sonia Grover, to Dr. Ardanu Kusumanto, and Dr. Sinta, and all of the participants, especially to the presenter also, Dr. Natina Viniasana. Today we will have a discussion on a case which is very interesting for us. This webinar series, especially on the pediatric and adolescent gynecology, will have us discussing a broad perspective of this PAG field. But most importantly, we want to get the best management for our patients. Thank you everyone for attending, and I will also would like to invite all of you, the participants, to participate in the discussion later on through the chat box in Zoom or YouTube. You can type questions or you can give comments and suggestions. You can also have an interactive discussion with us by using the raise hand function in your Zoom application. So for today, we will have a discussion on recurrent angiomyofibroblastoma, which will be presented by our resident, Dr. Natina Viniasana. Later on, we will have discussion from the panelists and also from the participants. So for the first opportunity, I will give it to Dr. Natina Viniasana to share her screen. The floor is yours, Dr. Natina.
Thank you so much, Dr. Dianisa, for the opportunity. And today, my name is Natina Viniasana, and I would like to deliver a presentation of a case that we are going to discuss for today, which is recurrent angiomyofibroblastoma. And these patients with doctor in charge, Dr. Ardanu Kusumanto, specialist obstetric and gynecology consultant, which will be one of our panelists for today. So the next slide, please. So this is the patient identity, which the initial of this patient is Miss FK. She is 15 years old, P0A0, and diagnosed with recurrent angiomyofibroblastoma of cervix. And the problems that we'd like to discuss for today are diagnosis and the management of these cases. Next slide, please. So we have been taking care of this patient for almost a year, since June 2020. And the first time the patients came to our hospital was in June 2020. She came referred from the district hospital with diagnosis vaginal tumor with differential diagnosis, fibroma and sarcoma. And the chief complaints at that time was bleeding from the mass. And then we performed a biopsy of the mass. With the result of the biopsy was mesenchymal tumor with differential diagnosis is embryonal rhabdomyosarcoma, vaginal lipoblastoma, epitheliate hemangioendothelioma. But unfortunately, this patient, we lost to follow up with this patient. This patient didn't ever come back to our hospital after the biopsy. So we lost to follow up these patients to do the further examination for this case. But then this patient came back to our hospital in October after 3 months after of her first visit. And then finally, we did the resection of the mass of these patients, and we did the histopathological examination, confirm with immunohistochemistry, with the result of the histopathological examination was angiomyofibroblastoma, which is quite different from the first biopsy result. And then after the resection, the patients didn't come back to the hospital after 8 months after the resection. In June 2021, the patient came back to our hospital with a new mass that came out from her vagina, with the mass size at that time was 6 times 3 times 2 centimeters. And at that time, we decided to do the observation of the mass because the size of the mass didn't really bother her daily activities or quality of life. But we ordered for MSCT abdomen to see if there is any infiltrative growing mass in the pelvis or even abdomen. And then the patient came back to our hospital in July 2021 with the CT scan result. And then we saw that the mass has grown progressively in size 20 times 15 times 10 centimeters. So yeah, so the history of this patient is quite complicated from the first time the patient came to our hospital, which is considered to be malignant embryonal rhabdomyosarcoma, and then after the surgery, we found out that the histopathological result was angiomyofibroblastoma, which is considered to be benign neoplasma. Next slide, please. Okay, so this is the physical examination, the last physical examination that we did in this patient in July 2021. So the patient BMI or body mass index at that time was 16.8 kilograms per meter square, which is considered to be underweight. And the vital signs is in normal limit. And also in the abdominal examination is in the normal limit. And as we can see here, there is a mass that growing so progressive came out that pulled the cervix out from the vaginal orifice. And the size of the mass at that time was 20 times 15 times 10 centimeters. But in this time, we didn't see any active bleeding from the mass, even though the color of the mass was red color. Next slide, please. So I would like to show you the history of microscopic feature in this patient. So this is the microscopic feature of the mass in this patient at the first visit of this patient to our hospital in July 2020. So as we can see here, there is a cervical mass that protruding out from the vaginal orifice. That the size was 10 times 15 centimeters with soft consistency. Next. Okay, so this is the 3 months after the first visit in our hospital, which we can see here. The mass is growing, but not that progressive, which is the size that at that time was 15 times 15. But as we can see here, the mass has pulled out the vagina out from the vaginal orifice. So after this, we perform the resection of the mass. And next slide, please. So this is the surgical documentation in these patients. At that time, as we can see here, there is slight prolapse of the uterus, which is assessed as prolapse grade 1 at the time. And then the mass that we took out from this patient, the size was 13 times 6 centimeters. And after we took out the mass, we saw that the surface of the cervix was in normal condition, and the mass didn't occupy all of the surface of the cervix. Next slide, please. And this is the macroscopic feature after 8 months of the resection of the mass. So this is the new mass that patients complain after 8 months of the resection. So as we can see here, there is a small growing mass that came out from the vaginal orifice. That size was 6 times 3 times 2 centimeters in soft consistency. And in a span a month, as we can see here, the mass has grown progressively with the size at that time was 20 times 15 times 10 centimeters. Next slide, please. So this is the histopathology history in this patient, where in June 2020, from the biopsy of the mass that we took out only small amount of the mass, it suggested as mesenchymal tumor with differential diagnosis was embryonal rhabdomyosarcoma, vaginal lipoblastoma, epithelioid hemangioendothelioma. But after the resection, the histopathological result confirmed by immunohistochemistry was suggested to angiomyofibroblastoma, which is quite different from the first biopsy and the second histopathological result, that angiomyofibroblastoma is considered to be benign and embryonal rhabdomyosarcoma is considered to be malignant. Next slide, please. Okay, thank you. So this is a brief histological appearance for the angiomyofibroblastoma in this patient. So as we can see here, there is ample of blood vessels that in this connective tissue, and then there is a spindle nucleus and some small oval round cells, and then eosinophil cytoplasma and eccentric nucleus. Next slide, please. And this is the immunohistochemistry confirmation for the histopathological result that suggested to angiomyofibroblastoma. Next slide, please. So we ordered MSCT abdomen as well in these patients in September 2020 and July 2021, but we didn't find any growing mass inside the pelvis or the abdominal of these patients. And there is no infiltrative growing mass as well. Next slide, please. So this is the case analysis in this patient. So the patients that came to our hospital in June 2020 with protruding mass and painless mass with the histopathological result at that time was embryonal rhabdomyosarcoma, and the patient finally underwent the resection of the mass after 3 months. But the result of the histopathology was the angiomyofibroblastoma, which is quite different from our first biopsy. But then after 8 months, the patients had the recurrence of the mass, which still suggested to angiomyofibroblastoma. So we will be discussing about the management of this patient, that will be surgical approach, which is total wide excision up to trachelectomy or hysterectomy if needed. And then we should reassess the mass with histopathology confirmation. Next slide, please. So this is the next plan that we're going to do for these patients, which is total wide excision of the mass up to trachelectomy or hysterectomy if needed. And then we should consult to pediatric psychiatrist for emotional and mental support, and then consult to dietitian. And points of discussion for today is how angiomyofibroblastoma is diagnosed and the management of the recurrent angiomyofibroblastoma. Next slide, please. So I would like to show about the brief explanation of angiomyofibroblastoma. Next slide, please. So angiomyofibroblastoma is actually benign neoplasma and it's rare. And the cause is still unknown, but the treatment is actually very simple total resection of the mass and almost no incidence of recurrence in this case. Next slide, please. And mostly this case or angiomyofibroblastoma is presents as a full form mass, but sometimes we can find the angiomyofibroblastoma in the cervix or even female urethra or fallopian tube. But in these patients, we found the mass grown from the surface of the cervix of this patient, and also the incidence of recurrence in these patients also growing at the same site as before. Next slide, please. So the clinical manifestation of angiomyofibroblastoma is actually painless growing mass that grown from the side of the mass, that mostly in vulva or sometimes for cervical or sometimes urethra. But if it's growing in the urethra or cervix or uterus, sometimes it causes the obstructive symptoms. But in these patients, the complaints of this patient was only painless of growing mass that grown from the cervix that protruded out from the vaginal out to vaginal orifice. And the dimension in this case have ranged from 3.8 to 25 centimeters. And in next slide. Next slide, please. Sorry.
Dr. Tia, can you hear me?
Yeah, I'm sorry, doctor. There is some trouble of the connection. So
Okay.
can I continue my presentation?
Yes.
Okay, thank you, doctor. So this is the differential diagnosis in this case of angiomyofibroblastoma, which is mostly our aggressive angiomyxoma, fibroepithelial stromal polyp, cellular angiofibroma, and any other benign neoplasma. But the most likely to be confused with angiomyofibroblastoma is aggressive angiomyxoma, which shares so many features with angiomyofibroblastoma in terms of the location, the histopathological features, and also manifestations. What different with the angiomyofibroblastoma is that aggressive angiomyxoma is infiltrative, but the treatment for both neoplasma is the same, which is total resection of the mass. Next slide, please. Okay, so what kind of workups that we can do to diagnose this case? So with histopathology to see the cell characteristic of this mass, and then transvaginal ultrasound or CT scan or MRI
Recording in progress.
Can also be done to do the preoperative assessment to see if there is any infiltrative growth and to exclude it if there is any malignancy in this case. And actually, there is no modalities that have superior or have higher specificity or sensitivity compared to any other modalities. Next slide, please. Okay, so the treatment of angiomyofibroblastoma is actually just total resection of the mass. And mostly the case of angiomyofibroblastoma that has done the total resection is there is no reported of the recurrence, the incidence of recurrency, and mostly curative because this angiomyofibroblastoma is considered to be benign. And also this angiomyofibroblastoma has no propensity to infiltrative growth. But in this patient, we found that there is a recurrency of the angiomyofibroblastoma, which is quite complicated and also challenging for us. So I think this is the last slide for my presentation, and that brings us to the end of my presentation. And I'd like to quickly recap for the case that I presented. So this is the case of a 15 years old P0A0 with diagnosis of recurrent of angiomyofibroblastoma. That was the first time, based on the histopathological biopsy result, was suggested to embryonorhabdomyosarcoma, which is considered to be malignant. But then after we did the resection of the mass, we found out that the histopathological research result was angiomyofibroblastoma, which is considered to be benign and had almost no incidence of recurrency. But in this patient, we found out that there is a recurrency that still suggested to angiomyofibroblastoma, which is quite rare. So this is quite challenging for us to do that, the diagnosis of this case, and also to decide the treatment, the best treatment for this patient, considering the age of these patients that is still young, and also the future fertility of this patient, and also the social and emotional aspect in this patient. And I think that's all from me. And I would like to return the stage back to Dr. Dianisa as the moderator for today. Thank you so much.
Thank you, Dr. Pia. That was very excellent presentation from you. So we have our discussion now. Before we go to our panelists, I have two questions in the chat box. The first one is from Dr. Anja. Why the presenter suggests the patient to get dietitian and psychiatric consultation? And the second one is, what are the risk factors for recurrent of this patient? Maybe you can add up a little bit about this, Dr. Pia, please.
Okay, thank you for the questions, Dr. Anja. So why I suggested to consult to the dietitian and also psychiatrist. So I consult to the dietitian in these patients because these patients has BMI, they're under normal limit, which is considered to be underweight. But if it's caused by this neoplasma, it's not correlated with the neoplasma that these patients had, because it's considered as benign and there is no clinical manifestation in losing her weight. So we should really think about the holistic treatment in these patients, also from her diet, also from her nutrition as well, to manage these patients. And yeah, also these patients lives alone with her father, which is quite concerning for us to support her nutrition every day. And also because of her condition with that mass, and that make her cannot going anywhere rather than just laying in her bed. So that's quite a big concern for us, because the nutrition also can affect her condition, I think. And then why did I suggest for the psychiatrist? Because this patient, for almost 8 months, she only stays in her home and never really go out from her home. And her father seems to be not communicative with her child because of his work, that he had to leave her child alone in the house alone. So this is really concerning also for us to support her mental and emotional support in this patient with the condition that she has. And I'm sorry, for the last question was,
About the risk factors of recurrency, because naturally this disease is not recurrent. Yeah. What about this patient?
Okay, thank you. So actually, the literature that studying about this case is still rare. And also there is almost no incidence of recurrency in angiomyofibroblastoma. So this is some kind of challenge for us as well to see, to confirm if it's really angiomyofibroblastoma or any other type of neoplasma. So, but from the literature that I've read, actually there is no incidence of the recurrency. So the risk of the recurrency of this angiofibroblastoma is actually unknown as well if there is any recurrency. I think that's all from me. Am I clear enough?
Yeah, I think that's clear enough. We will have another more discussion. We still have time. And there are so many questions regarding the management options in this patient. We will maybe hear from the panelists first, but one question is about the cause. Can you please explain briefly again, what is actually the cause of this benign cervical tumor?
Yes, thank you for the question. So yes, I stated before in my brief introduction about the angiomyofibroblastoma that the cause of this benign neoplasma is still unknown. And the case that have been reported also is still rare, and all of them have no known cause for that neoplasma. So yeah, I would say that the cause of this neoplasma is still unknown and still under research or studying. Thank you. I think that's all from me.
Thank you. So it's clear enough because it's quite rare, and this is a very challenging cases. You highlighted the view on other aspects, not only the clinical aspects of this benign tumor. Yeah. So we will have broader discussion with our panelists. Yeah. The first one is Professor Sonia Grover, MBBS, Franschhoek, MD. She is a clinical professor in University of Melbourne, and she's the expert of pediatric and adolescent gynecology, working in the Royal Children's Hospital, and also working as a research fellow in Murdoch Children. Maybe
firstly, thank you for the opportunity to participate, and secondly, thank you for the very good and very clear presentation of a very interesting case. You have obviously chosen a very rare problem. I have been doing pediatric adolescent gynecology and working here at the Children's Hospital for many years, and I have seen two cases which are in this sort of field of being benign, but nevertheless being a tumour. And as distinct from, yes, we do see sarcomas or rhabdomyosarcomas as well, but you're clearly describing something that is not malignant. Now, the two that I have seen were firstly a girl who had a vulval lump that was probably only 3 or 4 centimeters in size, and this is a very long time ago, but I think she was about 10 or 12 years of age, and that was completely excised, and that was the end of the story for her. The second one is a girl who I actually only met 2 years ago, probably, and at that stage she was a 5 or 6 year old girl who had initially a lump in her labia, I think, and then that was excised, but not excised completely, and then had represented with a lump that I think they took an abdominal approach to excise, and then she had represented again with a vulval lump. And by the time we opted to operate, again, it was benign. It was a 4 to 5 centimetre vulval lump that was causing her discomfort. And when we excised that, it certainly tracked down quite deeply into muscles and really into the groin area. Now, that would be 2 years ago. And I have my fingers crossed because I have not heard that she has had any further recurrence. But we were very determined to ensure that we tried hard to completely excise it. And I think that's your current challenge, that you need to aim to achieve complete excision. You're obviously very challenged by the fact that she's not appearing for follow-up. And that does mean that you're seeing this again when it has grown quite extensively. And I do note the question about why we're talking about a hysterectomy. Well, if this invades quietly in a non-malignant way but gets bigger and bigger, then it's going to involve the uterus potentially as well. And the only way to resolve this enormous growing lump will be to remove it, which may involve removing the uterus. But one would hope you'll get a chance to completely excise it by partially removing the cervix if necessary. And I think trying to achieve it that way would be the sensible thing.
Thank you, Prof. Sonia. So you have also experienced similar cases in your settings. However, it does not need hysterectomy in that patient, and there is no recurrent in your patient.
So no, but the two that I have dealt with were very much vulval, so I didn't get caught in that context of having to consider a hysterectomy. I can deviate a little bit to say that I have seen a young girl who had a rhabdomyosarcoma, so it was known to be malignant. She had a few cycles of chemo and wasn't responding particularly well, and this was of her cervix. And we took her to theatre, and what we found in this little girl was the tennis ball sized lesion that was very well demarcated. And she had a beautiful little uterus above it. And we carefully took out the lump, which involved taking out her cervix. And then we were standing there in theatre saying, you know, should we do more and what might need to happen, remembering this was malignant. So we took a biopsy from the upper vagina and asked for a frozen section. And our biopsy, our excision limits, so the vagina did not have any malignancy in it on the biopsy we sent them. And I did a uterovaginal anastomosis for that girl. So we've effectively done a trachelectomy. Now, the gynae oncologists are doing trachelectomies from below, so it could be done vaginally and take out the cervix if necessary, but you've got to get to the limits of the lesion. Now, my little girl who had the malignancy must be getting closer to menarche now, and reminding me to look her up to make sure that my anastomosis has worked and that she bleeds. It is possible to do a trachelectomy if necessary.
Thank you for sharing your experience, Prof. Sonia. We will ask the comments and remarks from the doctor in charge for this patient. I will invite Dr. Ardanu Kusumanto. He is a gynecology oncologist in our department in Universitas Gadjah Mada. He is also the head of our department and has been Yeah. So you can we can ask Dr. Ardanu expertise in this case. What are the considerations of these patients to be reoperated until hysterectomy? Please, Dr. Ardanu, the time is yours.
Thank you, Dr. Dianisa, for the opportunity. And I wish you good morning to Professor Sonia Grover. Thank you for participating in this case discussion. Yeah, at first, about a year ago, this patient was sent from other hospital with a description of vulvar or vaginal tumor. And she brought the result of histopathological examination, revealed sarcoma from the mass biopsy. As depicted in the presentation slides, clinical examination performed at that time we found that there was a mobile mass in the vagina with a stalk at the left lateral end of the cervix. So the mass is really attached from the tip of the cervix. The size of the cervix seems normal. The uterine body is pulled down and there was a uterine collapse. The size of the uterus is matched to the age of the patient at the time. And the parametrium and adnexa seem normal. And proof when we decided to do cervical mass excision, that time the mass could be taken off and the shape and the size of the cervix looked normal. The uterine body immediately returned to its normal position in the pelvic cavity. At the time, we did a clinical evaluation and we got the cervix, uterus, adnexa, and parametrium was in normal condition. The cervical tumor specimen that we took then was sent to the anatomical pathology laboratory and we found the type of Angiomyofibroblastoma without the signs of malignancy. Because the cervix is indeed a fibromuscular organ consisting of dense fibromuscular tissue, at the time I thought it was just a cervical myoma. So I only recommend monthly follow-up checks. But it seems that the patient did not do the monthly examination and came after the mass grew again. So I am planning an examination under anesthesia before we have surgery to assess the resectability and which approach we will use, vaginally or abdominally, as well as how far will the surgery go. I think that's for me, Dr. Dianisa.
Yeah, doctor. So this is a benign tumor and the chance to transform into malignancy is very low. No chance to transform into malignancy, right?
Yes.
But it's very progressive. The mass is very progressive. So your approach, the first one is a wide excision of the tumor, and the second one, you will try to also do the wide excision until hysterectomy, or you will have like what the Prof. Sonia experience about trachelectomy, doctor. Maybe you have comments on that.
Yeah. As I mentioned before, that before the surgery, I plan to do the evaluation under anesthesia before the surgery, so that we can be sure that to assess the resectability and then we can choose the approach Is it from vaginal or abdominal? Whether it's wet excision or trachelectomy or maybe hysterectomy, then we decided after the examination.
Okay, I think that's clear. Yeah.
From Dr. Dianisa and Professor Grover, we did a CT scan. Yeah. Apart from the mass in the cervix, there is a mass in the posterior body of the uterus that was also seen, which seems to be a myoma. So this may be complicated, will complicate the operation if we do a vaginal approach or abdominal approach if we do the trachelectomy, because we will have some difficulty to determine where is the normal tissue to connect the trachelectomy if, from the corpus and the vagina. Yeah. Yeah, so we still have to think about the possibility of hysterectomy. And this must be explained thoroughly to the patient, or in this case, the patient's guardian, because the patient is still a minor. Yeah.
Yeah, doctor. So we also have the problem of uterine leiomyoma in this patient. So it will makes another options, yeah, about hysterectomy with good informed consent and also information needed by the patients and the guardians. Maybe you want to add more information, Dr. Natina, about this patient. There is a question in the chat box asking what is the clinical reasoning of having MSCT scan examination in this case.
Yeah, okay, thank you for the questions. So the MSCT abdomen was ordered for these patients. We did that to see if there is any infiltrative growing mass from the cervical mass that grown to the pelvical organ or even abdominal organ. So, and also to exclude if there is any malignancy in this case.
Okay.
And also, yeah, and also the CT scan was done because to see the preoperative assessment. So I think that's all from me.
Yeah, thank you. I think that's clear enough about the modalities to establish the diagnosis at first. Yeah. Prof. Sonia, do you have any comments for the options that Dr. Ardanu already said just now? Maybe you want to add something?
No, it sounded very sensible to take that stepwise approach. What I missed was the size of the fibroid, the leiomyoma in the posterior wall. How big was that?
So it's very reasonable if we have a large fibroid, uterine fibroid also. It will...
How big was it, the uterine fibroid? What is thought to be a uterine fibroid?
Yeah. The posterior fibroid is how many centimeters, Dr. Kia? Do you have any information?
Yeah, so the size was 8 times 5 times 6 centimeters. Yes.
It's almost the size of the uterus itself, yeah?
Yes.
Yeah, I mean, I think that does, you know, again, a fibroid in a 15-year-old is relatively uncommon, you know, in fact, very uncommon. So I would be leaning towards thinking that a myomectomy needs to be performed to analyze and make sure that we're not missing something odd going on here. So, but the stepwise approach sounds very, very sensible.
Do you think we need to do another ultrasound, gynecology ultrasound for this patient? Because maybe in the last year, when she came to our hospital, there is no fibroid, right? if I'm not mistaken. And then while we're doing MSCT CT scan abdomen, we found the mass. Do you think we need to do ultrasound, gynecology ultrasound?
I think the CT scan sensitivity is much higher than ultrasound examination, Dr. Dianisa. But what I'd like to do, because we still have to wait for the schedule of the operation. While we are waiting, maybe I'd like to plan another mass biopsy to see if is it the same as the result of previous anatomic histopathology result from the previous operation. But I don't know. But I want to do that. I want to see. I want to do the biopsy.
Yeah, doctor.
That sounds sensible, because you want to be doing something that might change your management, and really another ultrasound is not really going to change your management, because you're going to be forced to make decisions in the operating theatre. And the big difference would be if this had transformed. We don't think they transform usually. This is nevertheless atypical. But if it has transformed, then all of a sudden, all of our management is being altered. If it still comes back benign, then taking a step-by-step approach, but making decisions in theatre, because some of these decisions ultrasounds and CTs don't tell us accurately where fibroids are placed. They're often misleading us. You've got to get in there and actually see, don't you?
Yeah. Yes.
Yes. All right, so it's clear that we need to do another biopsy and to do examination.
Dr. Dianisa, Professor Sonia, at this time, in many places in Indonesia, COVID cases are experiencing a significant increase. This requires concentration of resources to deal with it. As the result, many non-COVID cases that are considered less emergency are experience delays. Like from our human resources, our health workers have decreased a lot, because both doctors and paramedics have been exposed to COVID-19, so they need to be treated or self-isolate. We also experience times of oxygen crisis due to this surge in COVID cases. So we prioritize everything we have for treating COVID patients. We did have open a special ward for maternal patients with COVID, but like other non-maternal COVID wards, the number of patients who come more often exceeds our treatment capacity. So this affects the queue speed of our non-maternal patients, in this case, including our gynecologic patients like this child. So while waiting, I think I will take the biopsy and see what's the result.
Can you do the biopsy without giving her a general anaesthetic? Is it possible to take a small, a sample, given it the size of the lesion?
I think we can do that.
Yeah, so in this pandemic era, maybe that is the first thing we have to do, that we can do now, is doing the diagnostic approach, and also to relieve the symptoms, maybe, because the mass is very disturbing, yeah. As Dr. Natina said, the patient can only lie down in her house and cannot do daily living is impaired or not, Dr. Tia? for this patient?
Yes, so the mass that patient has is really affect the daily activities in this patient. So, and this patient is, I mean, like these patients did not continue her studying as well because of this mess. So
Yeah.
I think it's a bit concerning. I mean, like the size of the mess,
Okay.
even though it is painless. Yeah.
Yeah. Maybe you can tell us more about another aspects of this patient, because we want to approach this patient holistically, comprehensively, regarding her social life and also the economic life, maybe the environment, how she cope with this kind of condition, how her family cope with this kind of condition. She also has just lost her mom, yeah, her mother. So it might be a very difficult situation for her. And what do you suggest maybe to relieve her pain? Is it painful for her or painless? Or it's
It is
only
pain.
for mass, yeah? Maybe you can give some suggestion.
So yeah, the social and also economic aspect in this patient is also complicated because this patient is living in the poverty, I'm sorry to say, with the income from the father is around $100, around $100 or $200. And also this patient had just lost her mother who's taking care of this patient every day last week. So the social, the economy aspect in these patients is low in poverty, and that's also affect the management in these patients, because the reason of loss to follow up in this patient also because of the transportation. These patients live out of the city, I mean like out of Jogja in our city. It took around 2 hours from her district to go to our hospital, and also that's also can affect the future management in these patients because of that issue as well. And also, but fortunately, these patients had one caregiver or guardian that also support her transportation with free transportation from the primary hospital. And also that's also fortunate for this patient that she has that guardian. But still, these patients had no access to communicate to her friends, and also someone that can share her emotion that she has because of this condition. So I think it's really important to do the emotional and mental support for these patients.
Yeah, I think I
I
agree
think
with
that's all.
yeah, I agree with you, because these aspects is not directly influence the progressivity of the disease itself, but it can affect how the patient willingness to go to the hospital, the motivation, the internal motivation for her, and also the quality of life actually of the patient. So it's also a matter that we need to be looking at. Yeah, very important. Maybe Prof. Sonia Grover also already have the session a few weeks ago about the pediatric and adolescent gynecology, and it's very relevant about to know about the aspects surrounding the disease itself. So maybe Prof. Sonia, looking at this particular condition of our patient, do you have any suggestions for us, or maybe experience to overcome how we can support her?
I think your comments are very highly, valid and important. But here's a girl who's dropped out of school now, partly because presumably it was uncomfortable to sit on this lump. So we've got to get her back to school. She'll have the sense of my body is different. So she's going to have issues about her body image, and, and depending on what's done surgically, you know, am I normal? I won't be able to have children. Or even if you can save part of a cervix, even if you do a trachelectomy, there will be that anxiety of, you know, am I acceptable as a woman because I'm going to have challenges with having children. So there are several layers there of how this is impacting on her in terms of education, socially with friends, because I feel different, and personally that whole body image, self-esteem issue. So they're incredibly important things to address, which in some respects are occurring across all age groups, but remembering that teenagers are so much more engaged in, you know, how they're interacting with their peer group. They're still developing their body image and self-confidence. So it's a little bit different to looking after a 35-year-old woman who's already had children, who's got a relationship, who's got a job. She's already got those things established, whereas for this young woman, just at this point when she's developing all of those things, they're all being shattered or shaken. So I think addressing them is incredibly important, and you're absolutely right in considering those things.
Yeah, Professor Sonia. So we were discussing yesterday, and we thought that that is a good idea to keep in touch with this patient, to monitor her condition daily, yeah, because she's living outside Yogyakarta, 2 hours from Yogyakarta, and we monitor her and also have a connection with her caregiver, which is, I think it's healthcare providers in the area. Yeah, is it the cadre or not, Dr. Pia? Is it cadre or a social worker who take care of her now?
The caregiver was from social workers, doctor. Yes.
So we have to keep in touch to make sure that she comply to go back to the hospital and monitor her complaints. Yeah, so making her feel secure and feel being giving attention. Yeah, so it's very important for us to do that also. And maybe I would like to go to the chat box again, Dr. Ardanu. There is a question from Ricardo. In case this patient underwent trachelectomy, will this patient still receive any benefit for HPV vaccine, or shouldn't the patient receive any dose of vaccine? This is another issue, maybe if perform this procedure. What about HPV vaccination for this patient, doctor? Maybe Dr. can answer.
But HPV vaccination is not just for cervical cancer. It's for vulvar. Yeah, it's I think it's had to. It's no still she need to give HPV vaccination.
Can I ask what age is the HPV vaccination given in Indonesia, and is it a free vaccination?
Yeah, the HPV vaccination is a national program given from the age of 9 or 10.
So she's actually had her vaccination already.
I'm not sure that yet because it is a national program, but still it's a pilot project in several regions, not across all the country yet. Yeah.
Yeah, so the coverage of the vaccine is still not nationwide, of Sonia. So maybe this patient has not had her dose of vaccination yet at this moment. But Yeah, maybe we can ask her later. And as Dr. Ardanu said, that she still be benefited from the vaccine HPV itself, whether or not she will get the operation. Okay, we still have one more question from Dr. Regina. This is our resident asking about, is there any hypothesis in a quite different result between the first biopsy and the post-operative histopathology result? Maybe Dr. Pia can answer this. Why is it different, the first one and the post-operative result? Any hypothesis why is it different?
So thank you for the questions. About this issue, we already had a discussion with the histopathological departments about the difference between the first biopsy result and post-surgical histopathological results. They stated that the problem of the first biopsy result was because of the mass, the amount of the mass that was sent to the histopathological department is quite small and too small, so they couldn't really see it clearly of the cellular and histopathological appearance of the tissue at the time. But then after we did the resection of the mass and all of the mass, so they could see it clearly about the histopathological features of the tissue. So, but the hypothesis, if there is any transformation from embryonal rhabdomyosarcoma to angiomyofibroblastoma, is no. I mean, like, there is no hypothesis that stated that it could transform to angiofibroblastoma from embryonal rhabdomyosarcoma. And I think it's clear, and that's all from me, I think.
Yeah, actually, the first biopsy stated mesenchymal tumor, and the differential diagnosis with rhabdomyosarcoma and two other differential diagnoses. Yeah, so maybe the pathologist is still wondering, still have differentials, which need to be reconfirmed because the sample is too small. Maybe it's why it's different. It's like that, Dr. Pia.
Yeah, thank you for the confirmation. Yeah, that's what I meant. Because of the small sample, so she still suggested with mesenchymal tumor with differential diagnosis, embryonal rhabdomyosarcoma, and it's still, I mean, like, it's not clear enough to see which kind of neoplasma it was.
Yeah. Okay, thank you, Dr. Natina.
Yeah,
Is there any question?
Anita, maybe we should look for shelters as well as other social assistance for this child, and find maybe final support to cover transportation and other costs besides medical costs that have already borne by government insurance. I think we should look for that.
Yeah, I think that's a good idea, Dr. Ardanu, because the support, the financial support, should be continuously, because the patient will be going back and forth to the hospital, yeah, in quite a long time for the therapy. Yeah, maybe we can do that also, to help her to seek for the financial support surround her living area. Thank you, Dr. Adan, for the suggestion.
Okay, Dr. Dianisa, can I ask question?
Okay. Yes, Dr. Sita, please.
Okay, I would like to have a question for Prof. Sonia. Please explain more about the stepwise approach that you have already mentioned. Is it actually long operation with frozen section for the stepwise approach?
I think that's going, I suspect it's going to be challenging for the pathologist, but that's worth having a discussion with them preoperatively to see how readily they think they can distinguish on frozen section between the different tissues, but it's also going to depend clinically when you're operating, you know, what those tissues look like and feel like, and judging them from normal. So, but the junction might be quite challenging, but I'm sure that, you know, I'm not telling you anything that you're going to be surprised by, but you might find help from doing a frozen section, but you're going to go in and take a big lump to clear some way, and then you're going to see, well, where do I have to go from here? So it's going to be stepwise. Now, if you start following that and then you get a frozen section, or it's still looking horrid when you've at the top of the cervix, then you're going to start saying, I don't know that I can do this. So that's what I mean by stepwise. It's not, you know, go in and just chop it off or go in and do a hysterectomy. It's let's see what it's like when we've removed the bulk. Then let's see what it's like when we've removed what we're suspicious about. Can the pathologist help us? Are we confident we're at the limit? Because if you don't get it all out, you're going to be back there, and you will be doing a hysterectomy next time. So you're going to have to try really hard to be at your limits this time. But as I said, I'm not telling you anything you don't know. So, but that's what I meant by stepwise.
Thank you. Yeah. Okay, thank you, Dr. Anis.
Thank you, Dr. Sinta. So it's clearer for us that the decision to make further operation or which approach will we prefer, it can be done also during the operation, during the operation has taken place. And with also the pathologies, maybe with frozen section also. So it will have the best management for our patients. Is there any question from the participants? I invite you to ask the panelists directly, or maybe you want to add suggestions or comments, or also informations about this patient. Please, for the participants, do you have any question? I think in the chat box is already discussed everything. Any interactive participants wants to ask to Prof. Sonia or Dr. Ardanu? We have about 140 participants for today in this Zoom, and also maybe in the YouTube channel. Okay, do we have any question now? Oh, this is information from the committee. Okay, let's scroll up. Maybe we still have questions. From Dr. Supak, our resident, is there any place for chemotherapy administration for this patient? Dr. Ardanu, maybe you can answer.
It's Angiomyofibroblastoma with not malignant type, so we don't have any reason to give chemotherapy.
Yeah, because of the nature of disease is benign, yeah? You don't need chemotherapy. It will not be beneficial for the patient. All right. Dr. Natina, do you have any additional information?
No, I think, yeah, that's all the recaps for this patient is actually in this case, we should not only do the approach from the clinical aspect, and also we should support this patient in the mental and also emotional support, and also nutrition of this patient also, even though it is not give the impact to the neoplasma that the patient has, but it has the impact also as well, or could affect these patients to get the further management in these patients. So yeah, I think I already showed all of the information that these patients had, and also this is also a complicated case because of the social aspect and also economical aspect in this patient that could not support these patients to do the follow-up to get to go to our hospital to get the routine control to following up the case of these patients. Yeah, I think
Yeah.
that's it.
Another thing is, Prof. Sonia, in our culture, maybe this kind of disease, sometimes it's embarrassing for the patient and also the family. Many people will say maybe this is a curse. So you have this kind of disease. It's very awful. And it will bring the mental very down. Yeah. So we need to also educate the people of the surroundings that this is not a curse. This is it can be cured. Yeah. Do you have also that kind of culture in your country? Because in Indonesia, like COVID-19, also sometimes there is a myth about it. Yeah.
So no, I don't think I can say that we have a sense of a curse associated with this, but there are still issues with people not wanting to present because it's down there, it's genital, it's private, and that can cause a delay in presentation. Tying that to a curse is certainly not something that I've seen.
Yeah.
I'm aware that it happens in other parts of the world, and therefore it needs to be factored into your care if that's an issue within your culture. And those things are challenging. How do you get to break those cultural things that are saying that, we mustn't talk about periods, we mustn't talk about genitals, we mustn't talk about vulval itch, we mustn't talk, so there's a whole thing still about areas of healthcare which we're not allowed to talk about, which do mean that there is a delay in presentation. Or, the area that's being tackled here in Australia at the moment is talking about domestic violence, and encouraging people to actually talk and ask, that we as clinicians need to ask those questions because the people in the community are not prepared to volunteer that information. And as gynecologists, we know that already in the sense of, we realised when we started asking about urinary incontinence that in fact it was a bigger issue. Now, if we transfer all this down into talking about teenagers, coming to terms with their body changes, often don't know the language or the words to use about vulva and labia and vagina, and nobody's talked to them about periods, and so the whole area can be very challenging, partly because they don't have the language and partly because it's socially not the done thing to talk about those things. So breaking those barriers is incredibly important.
Yes. Thank you, Prof. Sonia. That is a very nice remark from you. And so we have to see this patient. She is not only vulnerable for the disease, but also vulnerable in the community, in her family also, for the social lives also. And that's what we want to support her, the very comprehensive support for her. Do you have any other remarks, Dr. Ardanu?
No, just thank you to Professor Sonia for your discussion and advice for this patient. So we hope we can give improvement for this child's quality of life. That is our goal, I think. Yeah.
And thank you very much.
Thank you, Dr. Ardanu. Ladies and gentlemen, participants of this webinar series, I think we already in the end of our webinar today. But before we close this webinar, I would like to invite our webinar director, Dr. Sinta Prawitasari, to give us our take-home messages from our discussion today. Dr. Sinta, please, the time is yours.
Thank you very much, Dr. Tianisa. Please for the committee to show my slide. Okay. For our take-home message, before I read our take-home message, I would like to thank to Prof. Sonia, to Dr. Ardano, Dr. Dianisa, and also for the presentant, Dr. Natina, for the great presentation and also for the great discussion. And for the close remark, I would like to read our take-home message for this case. So for the diagnosis, we need a biopsy first to make the final diagnosis, because the diagnosis is, it will also very important to ask for make a decision for the management. And for the suggestion from Prof. Sonia for the clinical management, we would like to take stepwise approach, and with during operation we try to before we during excision of the mass, we try to examine whether this is still is still available, or it's still okay to do trachelectomy, or if we have already decided that, oh, it's not the time the place for trachelectomy, then we will go directly to hysterectomy. And the final take-home message is that we have to do holistic management for the patient, because she's a teenager, and you know that teenager has a different approach in body image, in also in psychology, perception. So we have to support for the psychology matter and also for her nutrition, because she's underweight now. I think that's for the take-home message. Thank you, Dr. Tianisa.
Thank you very much, Dr. Sinta. That was very comprehensive take-home message. I hope that every participants in this webinar have a benefit from our discussion, especially management for our patient, the best management that we can have. And before I close this meeting, we will have a photo session, and I invite all of you, if it's possible, you can on your camera so we can have a group photo virtually. Yeah. Please smile, and the committee can just give us signal if you want to screenshot this webinar. Can be arranged. Dr. Nugi. Okay, you can give us, yeah, please.
1, 2, 3.
Smile, everyone.
Okay, thank you, doctor.
Already.
One more time, excuse me.
Yeah. I think there's a lot of frames here, 134 participants.
Okay, 1, 2, 3. Smile, please.
Okay.
Okay, doctor. Thank you, Dr. Professor.
Thank you very much. And lastly, I would like to thank every one of you, Prof. Sonia, Dr. Ardano, Dr. Sinta, all the participants, the residents, and everyone who joined us today. And see you again in another series. Don't forget that we already also have another case to discuss. Yeah, maybe in a few weeks later. And please have a good day today. And thank you for joining us and for your active participation. I will close this. Assalamualaikum warahmatullahi wabarakatuh. Good morning, everyone.
Waalaikumsalam.
Bye. Thank you.
Thank you.